welcome everybody. This is terrific. Now, this is going to be a little different from some of these others. So welcome to Course 1 of the Texas Medical Center overall Course 1. So this is the very first of a course. I've given a couple of these in prior lives, but this is the first one here. And the idea is the Texas Medical Center Health Policy Institute put 13 different seminars together. You will see them on the back of your cardboard. So, you know, you can have it on your thing at home, you know, the refrigerator or something on the back, along with the pictures of Jess's child and stuff like that. So these are happening every week for the next 13 weeks. And you're welcome to come. We are also streaming live. But the idea is this is actually a course that students can take. And there are 9 different schools who have students signed up to take this as part of their course. And it's going to be an hour and a half, and so the other hour and a half is getting filled in by others. And some will go to all 13, some won't. But it's a new way, we hope, of doing things. You know, I think Dr. Huff is, you know, we'll find out whether, gee, maybe we could teach medical physiology not having to do it 6 times to 6 nursing schools. Maybe we just do it once. So this is an experiment. We think it'll work. It ought to be fun. But what the idea is, and most of us are here, is that any of these are supposed to be lectures. They're not. What they're supposed to be are discussions, because you can read lectures and you can fall asleep to lectures, and you know, you will see you're not allowed to sleep through this one. But the idea is to have multidisciplinary people. And so again, if you look at you probably can't see from the back, but the people who are here, I think Dr. Raphael will be here in a minute. But we've got Dr. Michael Spear, he and I grew up together at Texas Children's, but Michael is here as a past president of the Texas Medical Association. My assumption, by the way, is you're speaking for yourselves. You're not speaking for your place. So you're speaking for yourselves, so we don't have to worry about that. Lamar Pritchard is the dean of the College of Pharmacy at the University of Houston. Dr. Anita Huff, professor and dean, Texas Women's University College of Nursing, sorry, even better. And Jessica Roberts, who runs the health law program at the University of Houston. Now, Jean Raphael should be here, who does both, is part of Baylor and Texas Children's and runs an institute there. Now, any of you, feel free, Twitter, #healthcaremyths. And if you're at home, this is being streamed live. You can look this tomorrow. You can go back and look this. You can go tell your friends. It's on the TMC Health Policy website, tmc.edu/health-policy. That's the way it is. So all of these will be there. Looks like Dr. Raphael approaching on horseback. Welcome. I introduced you. Wave to the fans. Terrific, glad you're here. So let me tell you how this is going to work. And that is, I'm going to read a statement. And you're going to vote, literally, true or false. And then I'm going to ask for volunteers who want to talk about why it's true or why it's false. And then I'm going to turn to the panel and ask the panel who might like to discuss that with the person that is speaking. And this is going to be sort of a fun round robin. Now, there's only one rule, and that's you don't get to change the words in the question. You don't get to qualify the question. Okay, so the first one is U.S. healthcare is the best in the world. How many true, how many false? You don't get to ask which world. Can't do that, right? That kind of thing, right? So let's do that, in fact, and the panel doesn't get to raise their hands because then they might give it away. But literally, how many true, U.S. healthcare is the best in the world? How many true? How many true? 1, 2, not a lot. 3, we're getting there. 4. Go for it. Okay, so how many false? How many couldn't care less and are already asleep? Okay, so would any of you that said, it seems like we have a little bit of a consensus, would any of you that said true like to say why? If you get, maybe if you just go to if you can get to the microphone, that's great. Or scream. Let's see how it works.
We have cutting-edge technology in terms of devices or pharmaceutical drugs or anything else. So it doesn't matter what disease, the best treatment is here. Now, affordability might be a different issue, but anywhere else compared to anywhere else in the world, I think in terms of technology, pharmaceuticals, biomedicals, anything.
Terrific. Great. Others who want to speak to that? Sure, go ahead. Scream or hit the mic. The mic's not too far away.
The last time I looked at the World Healthcare Organization's ranking, the U.S. ranked 1 below Morocco and 1 above Mexico as far as quality of healthcare. And part of that is based on accessibility. And of course, we have an accessibility issue here.
So do we think Morocco or Mexico are good or bad?
I've been to both and I don't want to be in the
Oh, okay. Okay, others on the true side. Okay, panel, true or false? Anybody in the panel want to say false?
I have to qualify it, Tim.
Oh,
I
excuse me for 1 sec.
have to break the rules. Because
Okay,
they've
go
both
ahead.
made some good points here.
Go ahead.
They've both made some good points. It depends on the measure you're using to determine what the quality of health care is. And that therein lays the paradox. But most Americans that report in terms of surveys that are done, and most of the national and international rankings that have occurred based on population health data and outcomes would not rank us at the top.
If your metric was spending, maybe we'd be one of the best systems.
That's coming.
But
That's coming.
And I think I would also add, too, it also depends on confounders. So you think about biology, genetics, we already talked about access. So a lot of times, I feel like with these outcome measures, again, it depends on the measures, but it depends on the confounders, because it sort of becomes one of those psychology tests where you see the butterfly, the ink spots, and it's sort of people see what they want to see. And depending on which confounders you use, you could say, well, we have the best system or we have the worst system, or it really becomes more complicated when you factor in all those other variables.
Jim, I think the argument could be made that the U.S. has the best disease care system with an approach from technology that was mentioned earlier, pharmaceutical sciences and those types of things. But healthcare, no.
The best schools of pharmacy.
There you go.
No.
There you go.
Okay, folks, what if I said medical care? But go ahead, Michael, and then we'll talk
let's
about...
go into medical care. Let's do acute, high-tech medical care. Strokes, cardiac attacks, small itty-bitty babies needing intensive care units who are cared for in true level 4 NICUs, which is the highest one you get. I don't think there's anywhere in the world that would match that. But, as has been pointed out, a lot of our population can't access that.
It's the delivery.
So what if I said we have the best medical care in the world? Uh-oh. Now, let's get somebody out there, what's the difference between healthcare and medical care? Somebody, come on to the microphone. This is a good conversation. Difference between health, go ahead, hit the microphone because they're going to get angry at me with the television. They're going to get angry at me anyway.
Is it on? It's the difference between fee-for-service versus population health.
Okay, so fee-for-service, medical care, population health, healthcare?
Correct.
Okay, others? Scream, face the world.
Healthcare is more inclusive.
Oh, there you go. Here's a...
It includes things like diet, environment.
And microphones.
Right, whereas medical care is a slice of healthcare.
Others?
I would say medical care is physician-driven primarily, whereas healthcare can be more comprehensive, everything from population health to nursing.
More, in the back. Hey, there's about 15 seats up front, those of you in the back. Come on up. Sounds funny. Okay. So what is a metric? Yeah.
So I'm Sharon from UT Health, and I'm a nurse case manager. So one of the things we look at is a patient related to multidisciplinary. So we have a social worker, thank you.
Wow, Adele,
We have a
thank you.
social worker, we have a pharmacist, we have a community health worker. We have myself as a clinical case manager, and we split up the practice at Bel Air Family Medicine. So I look at the medical piece, but the psychosocial piece, we're really seeing more and more patients have the medical component, but they're also having the behavioral health component, and access to care is a real challenge for us.
Really good. So what's a measure of healthcare? Measure of healthcare. You know medical care is coming. What's a measure of healthcare? There's two big ones. Huh? That's a way to get there. Two big measures. Yeah.
Value, so outcomes versus cost.
Nope, keep going. Mortality of infants. So infant mortality is a measure of healthcare. Why? Because it's big. Okay, healthcare, and I'll define it in a minute, but infant mortality is one of, what's the other big one? Life expectancy, okay? Now, think about, so when you say, okay, are we the best in the world in infant mortality and life expectancy? We bounce around the 50-50 club. We are terrible. Okay, we're 43rd, the most recent, and this really is interesting. When you try and go up, look, and you try to say, okay, what's the life expectancy of Cuba, It's the CIA that when they've got the best metrics out there. So the CIA tells us life expectancy is 43rd, and infant mortality 55th. So we ain't so hot at healthcare. Now, there is a paper that I would love, and I'm going to ask the panel. So panel, here we go, about whether you believe this or not. There's a paper that has been quoted since 1992. And by the way, all these sort of statistics and that I'm talking about, the references are on the TMC Health Policy website as of tomorrow morning. So all the things that you think I just sort of said because I made them up, we don't do that here. Not that anybody else does that either. So 43rd, 55th, here's a paper, okay? Michael McGinnis, who some of us know is at the Institute of Medicine. So the determinants of life expectancy. Panel, get ready to agree or disagree. 40% behavioral. 40% behavioral. 30% genetic predispositions. 15% social circumstances. 5% environmental exposures. And drum roll, 10% medical care. 10% medical care. Now, what medical care is in that definition is stuff that docs and nurses and those and community health workers, some, that's social work too. So that's what people think of as medical care. So medical care outcomes, myocardial infarction survival rate, breast cancer survival rate, those kinds of things that really relate to what, now, you can say, yeah, but that's also prevention. Back 20 years ago, and some of us are unfortunately, I'm probably the oldest, but it used to be thought that healthcare was prevention and medical care was all the rest of the stuff. Docs and nurses and all the rest of us are crazy about prevention right now, so you can't cut it that way. So, what do you think, panel, about 40% behavioral, 30% genetic predisposition, et cetera? What do you think?
So
Jess?
I teach genetics in the law, and I'm skeptical of 30% genetic. That sounds high to me because genetics that interacts with so many other kinds of things. So it's to say that genetic is something separate from behavioral or social or environmental. I think that's tricky to draw those distinctions. That's one thing. The other thing is that really I think now we have a much better understanding of the role of particularly income with respect to people's health, right? So talking about the social determinants of health and how that can affect things. And we know that your behavior can be incredibly influenced by your environment where you live, the people with whom you socialize, all those kinds of things. So for me personally, carving out these different percentages is something that I think is challenging, and perhaps now we better understand how all these things are linked.
So I think, going along those lines, I think social determinants of health has become such a major issue now, to the point where people are saying this is something we should incentivize with our healthcare providers. So you're seeing more grants from the federal government within Centers for Medicare and Medicaid to incentivize providers to really start to not only screen for social determinants of health, but actually to start to address them themselves. And so I think based on that data from that paper, as well as other papers that have found similar findings, not quite in the same percentages, there is this movement now to really start to address social determinants of health. There's also something called adverse childhood experiences, where people have shown that all these adverse experiences in childhood, sexual abuse, physical abuse, alcoholism that are experienced by children really impact their health over the course of their lifetime. And so all that data, even though some of it is really old, it's almost like everything old is new again, and people are really starting to get back into it.
Let me let these folks get, and then I'll get to you in a sec. Anybody
I
over
was
here?
just going to comment on the fact that when you listen to the conversations in any setting where the legislature meets, whether it's at the state level or the national level, they're very focused not only what the science is telling them may impact healthcare outcomes, but what can they impact. So we're more likely to cherry pick data and research that is supports our idea that it's amenable to some kind of policy that is either affordable or able to be actionable right now. And I think we're going to see a lot of influence and a lot of pressure and a lot of energy around selectively identifying those factors which can not only be validated that they contribute to health outcomes, but that can be impacted by some kind of action.
Terrific.
What we're talking about basically is epigenetics. It's the environment and our genetics and a bunch of other things, stress factors that are going to influence what our genetic DNA ultimately ends up. Any physician, any social worker, any nurse who's taking care of patients face to face know that behavior is probably the worst thing that we have to face. We can ask Mrs. Jones, did she take her blood pressure medicine, and she'll flat out look you in the face and say, oh yes, doctor, I took my blood pressure, then why is her blood pressure 180 over 120?
The machine's wrong.
No. Oh. and why patients are or are not compliant is a whole science in itself.
And I think that goes back to the social determinants point, which is we have to ask Mrs. Jones why she's not taking her blood pressure medication, right? And is it because she can't afford it? Is it because there's it makes her feel in a particular way, where there would be some other course of treatment that would be better? What is the cause, right? And sometimes, the reasons people might be non-compliant patients might be largely out of their control.
I kind of want to
Jump up.
clarify just some points on the statistics and where you get the 10%. What does that mean? It applies to 10%. Does it mean if you live 100 years, you're going to live those 10 years are due to your medical care, or how do you come about that?
Yeah. Okay, go ahead.
And then we can go back to infant mortality. That's a question I've had for decades.
You may want to ask there's a neonatologist far left here, to your right.
Given that we are so low compared to what we think it should be, why is that? Is it because there are more children born prematurely, or is it because we don't take care of the children as they're born? They don't receive health care immediately, a large part of our population? What causes us to be so low? Not just that we are, but what's causing
So far as infant mortality, there's a host of reasons. In the United States, you probably are aware that maternal mortality has risen over the last 5 years, not diminished. In Texas is a poster child for that. And that affects the outcome of pregnancy, because if mother is sick, then likely the fetus is going to be sick. If a fetus is sick, then the baby's going to be delivered early, and the baby's going to have the consequences of prematurity. Our social network post-delivery in infancy is poor in that patients' children don't have the access that they could have. Now, there are some statistics that sort of muddy the water, because there are countries that don't count a baby as being alive born until they're alive for at least a week or at least 24 hours. Or they count them as being live born if they're over 1,000 grams. So anybody under 1,000 grams is not counted in those mortality statistics. In Texas, if you're born at 22 weeks and weigh X and have a heartbeat, you're a live born baby, and you are going to die.
On that note,
There are some few 22-weekers that survive, but all of them have significant medical problems.
You're a braver I know you're a braver person than I am anyway, but I wind up saying something like that, and somebody jumps up in the fourth row and says, I was a 23-weeker, so we see this. The discussion I wanted to have is a discussion we just had. So here's the deal. They made that up. There was no empiric data behind that. And yet, okay, so here's the sort of take home. A bunch of life expectancy is behavior. A bunch of it. Killing people, right? The World Health Organization just added a 13th cause of death for life expectancy. What? Death due to terrorism. Well, guess what, folks? That ain't docs, right? So that's, I think, big point number one is life expectancy has a lot of things that go into it. Behavioral, smoking, drinking, alcohol, drugs, accidents, behavioral. A lot is social determinants, okay? A little is medical care. That's the take home from this, whether it's 10, 12, 8, whatever, that's the take home. Here's my favorite about social determinants. Those with more than 12 years of education can expect to live to 82. Those with 12 or fewer years, 75. Okay, now that's complex, right? It ain't the education that did or didn't do it, but it's all, there are a lot of things. And just like infant mortality, you want to go spend a lot of time getting confused, because there are probably 6 or 7 different things that go into infant mortality, and teasing them apart is a bear. So anyway, panel, other things before we get to number 2.
Well, Tim, I think getting back to that analysis that really wasn't an analysis, it was just a discussion of things that affect our health. When you look at the major issues in this country, chronic disease is by far, in my opinion, the huge elephant in the room. And we're doing very little to address that from a prevention standpoint, even though we want to. We know that most chronic disease is tied very closely with lifestyle habits. And yet, in our healthcare system, we typically don't address that until the patient has already become a type 2 diabetic. And by the time that type 2 diagnosis is made, the vast majority of those patients have a demonstrable occlusion in their vasculature. And the horse is out of the barn. It's too late. We know those heart attacks, those strokes, those peripheral events are going to occur. We try our best to prevent them, but we can't. They're ultimately going to kill 80% of all diabetics. But what we have not done is address that disease state from a preventative perspective. Are we taking children, looking at those genetics, and we all know it's nearly impossible to outrun our genetics, and are we putting them into a type 2 diabetic or a glucose intolerant prevention system to prevent type 2 diabetes from occurring? And Mike and I have this discussion. We are on a committee or two together for several healthcare systems. And while we talk about wanting to do things, we typically are not able to because of the way the system is structured. So how in the world are we going to prevent these children who have a very high predisposition to contracting type 2 diabetes from becoming type 2 diabetics?
That one's coming up. Hold on. Okay. Okay, listen carefully. There's 3 answers to this one. There's true, false, and don't have a clue.
I don't care.
American healthcare is the most expensive in the world. How many true? True. How many false? American healthcare is the most expensive in the world. How many haven't a clue? Healthcare, not medical care, healthcare. Healthcare. Okay? So if you want to calculate healthcare expense, prison expense, right? That kind of stuff. What percent of GDP, I just read about this yesterday, goes for prisons in different countries. And so if you're going to really talk about health expenditures, it becomes an almost insurmountable how do you know sort of thing. Now, let's put that aside and talk about national medical expenditures. So I think the vast majority of us would say, now, and here's the odd thing, I'm not the only human in the world that tries to make the distinction between healthcare and medical care, but of course, what the thing that we're about to talk about is written as is national health expenditures, just to be clear. So if you go look up NHE, you're going to get $10,348 per person on medical care. Okay, so you bet we are big time, okay? Big time, way ahead of people. What's next? Who knows what's right up there with us? What country? What's the next one down? Switzerland. Exactly, Switzerland. Huh? That's what it is. Huh? Now, I think, and just sort of a way to think about this, I'm not sure that percent GDP is helpful. And just the personal opinion, only because per person you get, but percent GDP has got to add to 100, no matter whether you're in India or Bangladesh or here or Kenya. It's got to add to 100. And so I think that's less helpful, I think. I was just looking up the percent GDP for military, and we're at 3.3%. The Canadians are at 1%. How come? Because the whole Canadian Navy is in Portland, Maine. So you've got to think about, when you're thinking percent GDP, just know that it's got to add to 100%. Now, we're going to talk about how come in a minute, but I do want to single out one area, and I'm going to ask Jessica to talk a little bit about the direct costs, and not, I can tell you right now, it's about $10 billion on the direct costs of malpractice. But talk to us a little bit about what your thoughts are about where malpractice litigation is going, and if there are people, and defensive medicine that I think we all may want to talk about. But kick it off.
Sure. So just in the interest of full disclosure, I am not a specialist in medical malpractice.
That's why I invited you. Oh, sorry.
However, so to speak to the point about defensive medicine, right? So for those of you all who are not familiar with how medical malpractice operates, right, we have something known as the standard of care that provides the legal standard, right? And so that means that a doctor has to act in a way that's reasonable, usually in keeping with what most other physicians in the specialty would do. And so because doctors and other healthcare professionals could also be the subject of malpractice actions, they might be concerned about being sued. So they might be inclined to offer more services, go above and beyond than what they might need to do to make sure that they are definitely fulfilling that standard of care. And you could get perhaps some excess services or something like that. And then lo and behold, if you have enough people doing that, then that becomes sort of what a reasonable person would do. And you can see how that skyrockets. This is why we've had some caps on medical malpractice lawsuits in terms of what people can get out of them to try to discourage some plaintiffs from going out there. But that is, you can see how they can snowball, and you can have a lot of doctors practicing what we call defensive medicine. How's that?
Terrific. Are there, before we get to defensive medicine, are there questions in the audience about the cost of malpractice litigation, defensive medicine, statements, thoughts, questions? Have at it. Yeah. Up, please, speak.
Medical malpractice cap here in the state of Texas. Why are our health insurance premiums so high comparatively? Do you know?
So
I thought that legislation was meant to reduce the healthcare premium cost.
absolutely. So that's a fantastic question. And if I could answer it, I would be a very rich person, right? I think that part of the issue is just Texas is just an underperforming state in a number of regards with respect to our insurance programs, right? If you look at something like how we deal with our folks on Medicaid, and I don't have good answers for you about why that's happening. That is in fact one of the justifications for why we want to cap what people are entitled to under malpractice actions. But it didn't have that desired effect, and I think that that's really the result, not just here but nationally, of the fact that we rely so heavily in the United States on a private for-profit insurance system, right? And so that there's the insurance companies, right? That it's not their fault, right? It's our structure, and they have a bottom line, and they're going out there and they want to get they want to insure good risks and not insure bad risks, and make sure that they get a payout before, that they get paid before you come and you actually, redeem the cost of your policy. So I think it's not just Texas. It's the whole insurance system.
Comments, Michael?
The cap on the payment on malpractice is pain and suffering, not on the medical costs that are associated with that malpractice entity. So the pain and suffering costs are capped. One reason that is given for that cap is that the plaintiff attorneys get about 60 to 80% of the pain and suffering, so the plaintiff actually doesn't get very much. Now they get less when it's capped, certainly true. But the medical costs throughout the patient's lifespan, and in babies, it's 18 plus 2, I believe. Anything that happened as a baby, there's 18 years plus 2 to file for malpractice on whatever the outcome of that baby's health aspect. So it did do one thing. You can like this or not like this. It did reduce malpractice premiums for physicians, for hospitals, for independent nurse practitioners, et cetera. And that seems to have brought a large number of physicians to Texas compared to prior the cap laws being established. So again, is that bad? Is that good? At least we have a neurosurgeon in the valley. At least we have obstetricians in some counties that didn't have any previously. But again, it's a debatable issue when you start getting down into the core.
It's a much better answer than what the lawyer could provide. So there you go.
So here's an interesting, at least to me, statistic as I was going through some of this stuff. Plaintiff legal expenses, $2 billion in the country. Defense, $1 billion. No wonder all those nice cars are going around, but twice as much. The plaintiff's lawyers are making twice as much as the defense lawyers. Sort of interesting. Anyway, defensive medicine. So I was I gave a little talk last month before, to a group of largely medical people and their spouses. And I said, so why is there so much testing in the United States? Why is there so much? And we'll talk a fair amount in the next one about this whole notion of fee for service. But so these are basically 50, 75 doctors and spouses. And I said, so what is that? What's going on? Why all these tests? Why all these procedures? What's going on? And everybody's hand shot up and said, malpractice. Okay, there you go. Now, so I, having not even had a drink yet, said, what about money? And there was this dead silence. And I'm not being invited back next year. And so what I can tell you is two studies that I found really interesting, okay? Basically, this goes back a long way, like 20 years ago. And they asked a bunch of docs, and they gave them categories of why you would do something. They gave cardiologists, there were 4 of them, cardiology, neurology, OBGYN, and general surgery. And they gave them scenarios, and they said, why would you do this, or why would you do that? And they were in an interview, and so they talked about it. And, the vast majority of them, oh, well, malpractice. They then did the same thing with a closed system where they were allowed to write down anything they wanted, and they could write it down. And only 5% said malpractice. So that then goes along with what just came out, and this is a good time to thank Ryan. Ryan, stand up for us, please. Ryan Hollywell, stand up. Ryan runs communications for the Institute, but is sort of the smartest human on the floor. So Ryan, and he gets to do things like tent cards and things. So thank you, Ryan. But no, this is a deal, right? So I hadn't seen this study. Ryan says, have you seen this? No. So a bunch of docs, this came out 2 or 3 weeks ago, a bunch of docs said, as in 71% said the reason, and again, this was sort of a closed, you had to answer, 71% said to make money. So we can talk some about that in a minute, but there is this tension in sort of why are you doing things? And I can tell you because I was on this panel that closed the Office of Technology Assessment 15 years ago or more. So there was this federal agency called the Office of Technology Assessment. And they did things like this, and they asked questions like this. And the last question they got to ask was, can you look at a chart and tell whether a practitioner is doing a test or a procedure because of defensive medicine? Can you look at a chart? And the answer is no. So the only way you're going to get to ask a doc or a nurse or a social worker is to ask them. Good luck. So that's what we're finding here. Anyway, thoughts, folks?
I'll put a twist in it.
Go for it.
Many physicians are now hired, and so the entity that hires them may make the money. So physicians may be in situations where they're encouraged to order tests in order for the entity to make money, so they may get a bonus, et cetera, et cetera. Most people in private practice don't own labs this day and age because the federal rules say you can't. And so if they order a test, they don't make any money on it unless they own the testing entity. All right, so there is a money aspect in this, but I would toss out something that nobody has really talked about, and that's habit.
Oh, yeah.
Doctors in medical school are taught how to care for patients, including ordering tests. Unfortunately, in this day and time, the clinicians have been forced sort of out of the medical school environment in large part, and you have laboratory docs now taking care of clinical patients 2 months a year. And they're not quite as assured as they were 25 years ago. And so they have a tendency, this is anecdotal, observational, but they have a tendency to order everything just because they can. That teaches students and residents bad habits. I consistently, on a daily basis, because at Texas Children's, where I work, Texas Children's, you order a Chem 7, okay? 7 tests. Is there a break? Is there does the patient pay less for 7 as opposed to ordering 7 individually? Nope. 7 tests are 7 tests. They're charged for 7 tests. Most of the time, and there's a Chem 10, and there's a Chem 26. Most of the time, many of those tests in those panels aren't necessary for the care of the patient, but it's easy to write Chem 10. And so they will write Chem 10 Q6 hours where they may need a set of lights, which are 4 tests, once a day, because it's habit. That's what they were taught. And it's hell to break a habit. So I'll toss that out for discussion.
Yeah, speak. It's fun. Go. Yes, sir.
Well, there's a fair amount of data that the frequency of test ordering and procedures in general is highly correlated with the supply of such things, so that if there are more MRI devices in an area, then there's a much higher frequency. The same thing with the types of physicians and such, and testing facilities and things. So I can't think of an easy explanation for that, other than one is, generating increased revenue from that. And it seems to me that, if things are slow, that one would tend to order those things, and that in addition, there aren't disincentives generally for ordering those sorts of tests.
Yeah, I would agree. In some instances, hospitals have put what the charges are on the ordering electronic sheet. That has actually diminished the number of tests and diminished the cost. I wish everybody would do that, frankly.
And I've got a feeling it's going to, that's a piece of some of the federal legislation that's been proposed, that we have to have full disclosure on costs of everything and everything they charge.
Sure. And I want to tie this back to the insurance point, right? Because we're talking primarily about physicians.
Maybe
right?
go ahead and stand up.
But
if you know, I mean,
individual me?
Yeah,
Sure.
yeah.
But individual people too can so individuals can also overconsume healthcare, right? And one of the things that we have is this possibility of what's known as moral hazard, right? So if you have a good insurance program, right, and you're very well covered, and you might not necessarily need a particular test, but you say, like, what the heck, I'm not the person paying for it, right? And we're talking about people that actually have good insurance coverage, right? So this is something, at least with respect to the insurance law literature, people are very concerned about this problem of moral hazard as a source of overconsumption of healthcare in the United States, beyond just the physicians perhaps trying to profit.
Gene?
So I just wanted to add to, I think another issue in there that's related to this is just sort of increasing culture of consumer-directed healthcare.
Yeah.
So if you looked at all the direct-to-consumer advertising, people want more out of their healthcare, and they want to feel in control of that. So if you just go down, I think it's the corner of Holcomb and Greenbrier, there's a place called Any Lab Test Now. And just like it sounds, you can actually get any lab test now. So think about it from a perspective as a doctor. You know that's out there. Patients want to be satisfied. So now if they say, I can actually bypass the healthcare system, there is another mechanism for me to actually just find out all these simple things. Am I anemic? Am I pregnant? Et cetera. So I think that motivates doctors to try to, in a sense, compete with those other mechanisms that are outside the healthcare system. So now I think it becomes too sort of this issue of patient satisfaction. My patient wants this test. My patient wants this battery of tests, so I will do it because if I don't, they're on the corner of Greenbrier and Holcomb.
So I want to respond to that, and there's a paper that I looked for a long time to find a couple of weeks ago, and I remember the data, but I can't find the paper. And that is the end game of it was, and I'm pretty sure it was Family Docs. I'm not sure, but I think it was Family Docs. And 68% said that when somebody came in with an article or an advertisement and said, I want this medicine, 68% of the time they said, okay, unless it was dangerous. And the thing that came was just because they don't have an hour. So I want to say something I've been dean of 2 medical schools. I want to say something in defense of doctors. It ain't easy, right? And so here, oh, look at what they do. I remember I was sitting outside a person's office across the street, across Fannin, and this is 20 years ago. And when you were allowed to put machines that were very expensive machines in your office, and you could do certain imaging and those kind of things. And I'm sitting out there waiting to talk to the doc, and the salesman is sitting there saying, you realize if you don't do 8 of these a day, you're going to lose money. And well, yeah, I get it. So this stuff is complicated, and I back to Michael's habit. How about the prevailing, you all probably read the Atul Gawande expose of South Texas, where they're the second highest in McAllen, the second highest cost per person in the country. And I don't think, I'll bet you it wasn't conscious, that's the way we do it here. And so we got to not do it that way here, but there are, a lot of, this is complex stuff. Yes, sir.
Yeah, well, actually, you actually make my point that as we continue to make this argument that we tie physician reimbursement to patient satisfaction, you will see this, especially in this age where so many patients are tech savvy and they're on the internet. They come in basically demanding tests, and if you don't order it for them, they'll see another physician and then pretty much smash you on all the social media sites.
I think
Sure.
you've both, go ahead. You go ahead.
I was just going to say there's one more point that we haven't discussed, and that is the duplicity of our system and the inefficiency of our sharing of information across different healthcare systems and institutions. I had the privilege of serving on the board of directors for the Greater Houston Health Connect. And we were given the job of trying to tie together all of our institutions within a 15-county region that had, nearly 12 million patients. And we saw just time and time again someone having a car wreck in the Woodlands, and all these tests were run at this particular hospital system. They were discharged, went home to League City. They were then seeing their physicians there in League City who ordered every one of those tests over again. MRIs, very expensive tests. There's no sharing of information. Our patients think that we practitioners are sharing information between our offices, our institutions, our nursing homes, but there is very little sharing of information. We have the ability from a technology standpoint to do this today.
Yeah.
We set up this system within the Greater Houston Health Connect to do it. But where was the greatest resistance for sharing data? The systems. The systems say, we own this patient's data, and we're not going to share it with another system.
Especially the patient.
And until the patient demands ownership of their healthcare data, and they demand sharing of that data through all of the physicians, all of the healthcare practitioners, all of the institutions that they see and frequent, we will have this duplicity. Not only because of greed or these types of things, it's just an inefficient system. And you learn that some of the major players within our TMC just this year converted over to electronic medical records.
The same system.
You go, oh my God.
The same system, but they don't talk to each other.
They don't talk to each other. And it's really frightening. And when you're an emergency room physician and you're seeing a patient you've never seen before, and they're unconscious, and you have no access to their data, you're practicing medicine in the dark, doing the best job you can. But we have the ability today to change that. But yet it's our system that won't allow us to do it.
Anita, thank you. Terrific.
Oh,
Yeah.
I was just, all of this is connected to the kind of relationships we as healthcare providers have with the patients that we care for. And I think the writing that's on the wall for me, I don't know about it, I think it's certainly been on the wall for nursing for a long time, is that our relationship and our roles are going to have to change. If we're going to be able to manage healthcare, if we're going to be able to engage with patients in a way so that they don't overconsume or that they are compliant with things that they might be needing to do, and that we understand what they really want. Some people don't want the outcomes that we think we want for them. And we don't bother to talk about that. And we waste a lot of time and a lot of healthcare dollars trying to have them follow some clinical pathway. I think the whole issue of our roles, our relationship with patients, who owns the data. The Federal Trade Commission would say down the line, it was at a recent meeting that I was in Washington, that patients should own that information. Yeah. They should be carrying it with them wherever they go. And they do have a right to go down to the corner of wherever that was. But they have an obligation to bring that data back to their physicians.
One here and then one in the back, and then we're going to move on. We got four more to go.
So I just got really excited because one of my areas that I am interested in has to do with the ownership of health-related data. So I specialize in genetic data, but it is really interesting. It actually, I'm working on a survey of states looking at ownership interests in various kinds of information. And for the most part, I heard some surprise in the audience. It is true that the institutions own data. There is a movement. I think in some states, actually, they've legislated that the individuals own their own medical records. But really, it's only recent that we're seeing individuals being able to get access to their records. Like the HIPAA CLIA regs said that, okay, an individual person can actually request her test results directly from the lab. And it used to be you could not do that. You had to go through a provider. And so there's some interesting stuff happening with respect to Myriad Genetics, whom you all might have heard of. But people saying, hey, I want all my test results. And the company's saying, no, that's part of our private database that we want to monetize.
Great. In the back.
I got a question for the gentleman who was talking about not sharing the data. Would that be considered as a malpractice?
It very well could be.
Okay.
And let me give you another example. You've heard of the Moonshot Initiative.
Right.
To try to find cures to cancer that we've been working on for centuries. Vice President Biden's son Beau died of glioblastoma recently, and he was talking to us during this Moonshot meeting, and I was with Ron DePino for this over at MD Anderson, and he said when Beau had his test done in Bethesda, we sent all of this data to MD Anderson, to consulting physicians down there during this very intense, highly technical procedure he was undergoing. And he said, you would have thought we could have done this efficiently, but what we had to do, we had to put it in a car on the curb at the hospital, take these records to Andrews Air Force Base, fly them down to Houston to Bush International Airport. MD Anderson had to send a car out to Bush, transfer these records to the physicians at MD Anderson. They analyzed it for a couple of hours. They sent their professional opinions back, and it was backtracked, and it took nearly a day. And this was with the most sophisticated transportation network available.
Okay, crew, you're going to get angry at me if we don't get through this. So, thank you. Okay, now,
but
you guys got to go to work. You guys got to go to work. Done.
But this could have been done in a millisecond had we been using this data transfer system that's already established.
Okay, true or false? America wastes, now, you got to vote. America wastes half of its medical care dollars. True or false? How many true? How many false? Oh, God. How many aren't voting? Yeah, there you go. Okay, so it's about a third, a third, a third. Okay, I'm going to get you close to this because I want to hear from you about why. The number is actually a third. And you'd say, where the heck does that come from? And there is an article by Don Berwick, who some of you may know, some of us know him better than others. Don Berwick was the person that wrote the Institute of Medicine treatise on medical errors and was the first one that said there are more people killed per day than a 747 crashing. That was the early Don Berwick. Don went in, and this is, you can go look it up, it's in JAMA in 2012, and he has 6 areas, and I'll tell you what they are after you tell me what they are. But the total is $910 billion a year. Now this was 2012. And so in that, healthcare is now, or medical care is up to 3.3 trillion. It still is probably about a third. When I heard that the first time, I heard it before Don, I said, but you know, somebody just pulled that out of his ear. No, this is actually fairly well, you can agree or disagree with it. But tell me, just hold your hand up and stand up and say, what do we waste money on? Yes, sir.
Third-party administrators of health plans.
There's at least one of those that I saw walk in here. Yeah, go ahead. This is great. More. Okay. For those of you that don't do this every day, it's infections you pick up in the hospital. Yes, sir.
Excessive testing.
Excessive testing. Next. Huh? Medication. Medicate. You mean, say some more.
Overprescribing.
Too much stuff. Great. Okay. More. The back. You're not supposed to sleep back there. Huh? Futile care at the end of life. Great. How much do we, what percent do we spend in the last year? Not half, it's 10%, but that's $330 billion. Yeah.
Medical errors and inappropriate prescriptions.
Okay, medical errors. More in the back? Shout it out. What are we wasting money on? We've missed some big ones. Yep. Readmission rates, okay? It's on the list. Treating and not curing. Okay, like that. Okay, more. Misdiagnosis. Inflated cost of pharmaceuticals.
Lack of collaboration among medical entities.
Say a little more about that. Lack of collaboration among medical entities, but keep talking.
Every institution has to have all of its own stuff instead of sharing it.
There is a little of this to what Dr. Pritchard was talking about, which is my MRI is better than your MRI. And by the way, somebody has to pay for it. So there's a little of that that happens too.
And then, unfortunately, not all readers of MRIs are equal.
Yeah, I'm better by definition, right? Yeah, right. Okay, yeah.
Medication noncompliance?
Medication non-compliance. I wish we could go back to that. The big deal word right now is medication adherence, and I always think of Band-Aids. You know, adherence, you know, but anyway. Yeah, more.
Unnecessary care.
Unnecessary care. We're missing a couple of big ones. Yeah. So you get, yeah, it's like the shampoo people tell you that you got to use, or you got to rinse and do it twice, right? Where'd that come from? Yeah.
Fee-for-service business model?
Ah, the fee-for-service business model. Yes. More. We're missing a couple of biggies. Unnecessary surgery. Yep, absolutely. Unnecessary stuff. Yeah, in the back. And hold on. Yep. Say that. I just didn't hear you well. So you keep doing stuff? Yeah. Well, you know, it's a little bit of cart and horse how the 8-minute doctor visit happened, right? Insurance overhead. Yeah. This is great. Not using technology to its benefit. Yep. Use of emergency services for non-emergencies. Yes, sir. You're getting most of them. Yep. Readmissions. Yeah, we had that before. There's a number here. Yep. 3 more, and then we'll get to the data. Yep.
Lack of housing, lack of transportation for patients in the ward.
Wow. Okay. So social determinants, folks. Yes. Great. Uh-huh. Fraud. There you go. Isn't that great ad about the frog instead of the fraud? Right? You know, can you take care of the frog? Frog? That's great. Yeah. Okay. Yeah.
Lack of patient education.
Aha. We're going to come to that. Yeah. One more. Last one.
The extra salary male doctors get just for being male.
Well, let me give you an interesting thought about that.
He got applause.
I happen to have been a big nurse advocate in my previous life.
And you're going to go to heaven for that.
Oh, yeah.
That's okay.
I'm going to see you on the escalator. I'm going down. Right? You know. But nurse practitioners are paid 85% of what physicians are paid for the exact same service. Now, put that in your pipe and smoke it. You know, that's just moronic. But, and, you know, yeah, we're getting more and more, you know, there are still more male docs than female docs and more female nurses. So some of this is that, but the 85% just blows me away. Should not happen. Yeah.
If I remember correctly, Indies nurse practitioners have better outcomes than physicians.
They do. They're, go ahead.
We're more likely to overdiagnose things, but we're usually accurate. We don't miss things as
there you
much.
go. So I've not seen a study, this is going to be about 3 negatives, where the patient satisfaction wasn't higher with nurses. So the patient satisfaction's higher. Okay, here's the data. Failures of care delivery. Now, there are these great, I sort of put my own words in because goodness knows what it really means. That's safety. Okay, so that's $128 billion a year. Now, what does that mean? The subsidies currently in Medicaid and the exchanges are about $90 billion. If you did all over the country, if you fully funded all of that, it's about $150 billion. So put in your thinking that probably the uninsured are around $150 billion. So put that in your thinking. Okay, failures of care coordination, that's readmissions, $35 billion. Over treatment, we're going to come back to that, $192 billion. Overtreatment, 192 billion. What's overtreatment? All that stuff we've been talking about. Administrative complexity. Now, that's all the stuff that is, you get asked 3 times for your name between 9 and 10 o'clock when you go to the clinic, and all of that other stuff. So administrative complexity, that's not profit, that's the next one. So this is called pricing failures, but what that really is, and in most studies, it's about 3x. We're about 3 times the price that people pay here for an MRI is about 3 times what it is in much of Europe. That's the number. There's a funny one about doctors, because they say the same thing, right? They say docs here make about 3 times what they make in Europe. Problem is they don't account for the private practice of the docs that may not be reported. So I just don't, certainly the public pay for physicians and the pay for physicians here, it's about 3 times. I'm sort of, interested in this kind of stuff, and so there was a cab driver in Costa Rica driving me from the airport to a meeting, and so I said, gee, how do you pay for health care? He said, oh, we have it in our taxes. I said, oh, okay. Do you know what % of your income? He said, yeah, it's about 5%, and that's the number that I sort of like. And I said, but it's got to have a cap, right? I mean, it's not 5% if you make $1 million. He said, oh, no, it's 5%. I said, how's that work? He said, we don't tell them what our income is. Okay, pricing failure. So we are more expensive. Now, the whole fee-for-service thing is part of pricing failures, part of overtreatment. And a lot of these things sort of overlap. And then, as one of you said, fraud and abuse. A lot, 177 billion. So in order, administrative complexity, 248, overtreatment, 192, fraud and abuse, 177, safety, 128, pricing and care delivery about the same, and then readmissions 35. That's where, and so if we're all thinking that we have 1/3 of our dollars being wasted, that's something that we ought to go after, I think. So thoughts, panel, pricing, things.
Well, one interesting thing is, that sort of was in vogue for a while. People were really talking about readmissions and how to try to get readmissions down. And so I think a few years ago that was a big topic in healthcare policy, and I think it ran into a number of problems. So one was, what was the appropriate length of time to think about readmissions? Was it 7 days? Was it 14 days? Was it 30 days? Did it vary depending on age? Did it vary depending on disease type? But then there also came this complexity of how do you account for social determinants of health? Because what people started doing at a federal level and a state level was starting to apply these penalties for high readmission rates. But then hospitals started to say, well, our patient population is fundamentally different, so how can you penalize us? Because the patient population that we have has all these social determinants of health impacting how they receive care, how they transition out of the hospital. So I just think it's kind of fascinating to see how people try to attack this one particular thing on the list, readmissions, and it sort of came up and then it sort of bubbled down because it got really complex. And so I think with all of these, you can kind of go into detail. I'm sure other people can better than I can, but once you get into the hairs of it, it really becomes complicated.
So I'll give you a really interesting, to me, example of that. So 30-day readmissions are the sort of coin of the realm. That's what places get penalized for. If you're above the median, if you're below the median in the country, you don't get paid. You get penalized if you're in the lower 10%. 30 days. Some are now wanting to look at 90 days. Some are now wanting to look at 6 months. Now, the deal is all cause readmissions, right? That means no matter what. Why? because people tend to decide that, well, that renal failure didn't have anything to do with the heart. Wrong. And so the CMS just said, enough, anything. And so when I was at Virginia, this guy, they sort of created a furor because his heart failure was fine, and he came in month 4, and his wife shot him. And missed. Now, you know, it's one thing, you know, and the way this readmission thing works, if she'd hit him, he would have been out of both the numerator and the denominator, but she missed. Michael, you had something you wanted to say? Oh, okay. Yeah, and then we're going to move on.
A comment and then a question. The comment on the readmissions is there was a very good paper about 2 months ago where they were finally really monitoring that in a big study on the West Coast. And they were able to drive down admissions, readmissions, but mortality went up. And so it was drawing into question how you take an arbitrary measure like that and then try and work it and then what the consequences are. But the deeper question is, I've heard time and time again how this billion or $1.2 billion at this point maybe,
Trillion?
but all this waste.
Trillion.
Yeah, trillion too, is somehow, oh, we can just capture that. We can just change the system in some way. But all that waste is profit. And all of the legacy players in healthcare are dependent upon that, and in fact wouldn't like to see that go away at some level. They might personally, but the not only the insurance industry, but the major hospitals, the specialist physicians, all of them would be really negatively affected. And so is it possible to really get rid of that from within the system?
Panel, yes, no?
Well, we see what happens.
Thank you.
Politically, when the cheese is moved, or even talking about moving the cheese, you know, this whole eruption happens within our country. And you're right. The U.S. healthcare system does not want to stop making money. It has been established in a serendipitous manner. It's been allowed to grow just, you know, willy-nilly. And anytime we do talk about these major changes, you know, you have eruptions of those who don't want to give up the dollars they're earning. And as much as we want revolution, I think we're stuck with a very, very slow evolution. And, you know, I think picking out, you know, these places to start like readmissions is probably as good as it's going to get in the near future. And, you know, you look at Texas, we have horrendous problems here. And we have more uninsured patients than any other state in the country by far.
Either by percentage or numbers.
Or numbers. And, you know, here we are with these huge needs. The federal government has the ability to help us with a program like Medicaid expansion, but yet we're saying no, you know, keep the $18 billion that you would have sent to Texas and send it somewhere else, send it to another state, and our problems continue to get worse. And I think we all realize these problems are here, but the system doesn't want to change. So, you know, and I guess we are all the system. We're all in it. And what is it going to take? It's going to take, in my opinion, an extraordinary leadership to say enough is enough. You know, we can't continue to allow this to happen. And that's going to have to overcome the current status quo. And such an individual has not come to the forefront yet. And is it an individual? Is it going to be an organization or an entity? And I think when we look back at our history, it's taking these movements to say, we're no longer going to allow children to work in these factories and be killed when a fire happens because the doors are locked, because we won't let them leave. You know, it takes those horrendous things for this change to happen, but yet it's going to be evolution rather than revolution.
So let me get you depressed a little more. I've spent a fair amount of time in the last several years on readmissions, and I can tell you from downtown Paris to rural China, hospital CEOs want to keep their beds filled, and they don't want readmissions to go away because they get paid for them. So this is not the US healthcare system. This is the world healthcare system, which makes it more complicated because it really is money driving stuff, and it makes it more complicated. So you're going to have a UN leader or something. Yes, sir. Yeah.
I was just about to comment. I mean, that's the fee-for-service model.
Not just a fee-for-service model.
Well, and perhaps you could educate me on that. My understanding was the ACA attempted to shift from that model to a population health model where the systems would take a bigger share of the risk away from the insurance company. Therefore, the incentive is to keep the population healthy. And that fundamentally would take care of it. That's my understanding. Perhaps you could educate me on that.
I think we're going to get into preventive care
Right now.
shortly, which may in part answer or deal with your question or statement.
Okay, here we go. Now, for real, wake up. 13 minutes. Preventive care saves money. How many true? Up high, how many true? Preventive care saves money. All right. Now, I really want some of you to talk. Okay, how many false? Preventive care doesn't save money. So less. Now that everybody else has voted, panel, preventive care saves money. True?
There's so,
It depends.
yeah, it depends. I would,
You live longer, you
Sometimes
spend more
false.
money. You use the system more, you
All right.
spend more money.
The true, speak. Where does preventive care save money? How about true? Huh? Vaccines?
Good one.
Yep.
Good one.
Yep. Good one. Yep.
Several of us in the room are on the front lines of transformation and working with preventive care and the ACOs. And what we're finding is that the clients are also participating. So we end up with a team effort working with the family, the support system, the physicians, case management. And it does end up saving money because we're able to head off some of those, end organ damage. It's pretty exciting.
More. Preventive care
We're funded through the
saves money.
district
Huh?
program. We're funded through the district program.
Right?
So I see, and I've been with them for about 2 years, I've really seen the case management aspect really show prevention really works because I'm there doing it. Not to toot my own horn, but we as case managers are doing that, and I think we're showing some successes in some of the studies we've shown.
Smoking prevention programs?
We'll get there. Hold that thought.
That's an interesting one.
Unless there's a different definition of preventive care,
Uh-oh.
I'll just take diabetes care, right? If you take care of diabetes earlier on, the cost of preventing that disease, taking a life down the road, or even the cost of care down when you didn't prevent it, is going to be multiples of what will have been if you were just taking is it statins or whatever it is that you do to prevent that. So that's a simplistic view, but I'm sure there are much more learned people in this room that can probably explain preventative care a little differently.
More. Yep.
Birth control. Oh, but you need a workforce.
Got it. Okay.
Yeah, but eventually
Okay.
they
So
get
I'm trying to figure out
jobs.
whether you're true or false. I got it. Okay. I didn't say that. Okay. Got it.
Is if people are poor and they're unable to have access to health care, by the time they get to a hospital, something that could have been handled in a doctor's office, it becomes this emergency room treatment and the costs go up. So just a poor person, when we're looking at social determinants, having access to care, preventative care, and reducing those trips to the emergency room, which are very expensive.
Two more. One, okay, hold that thought. Yeah. Last one. Somebody was waving. There you go.
I think part of the preventive care problem is the reimbursement, again, comes back to the money part of it. Reimbursement is very poor for preventive care. You know, some of the things that could be done for prevention, they don't get done, you know, because it doesn't cost, it's not cost effective for, you know, a 15, 30-minute doctor visit, you know. So that could be part of the problem.
Okay, here we go. Now, I'm going to maybe say it twice or 17 times. The fact that preventive care largely doesn't save money is not an indictment of preventive care. So let's be real careful, right? Preventive care, I would bet you everybody up here is saying, well, goodness, you have to do preventive care. Of course you do. Of course you do. Because the purpose of this is not to be a very sick, very wealthy person, right? You want to be well, all right? So don't take any of what we're saying to say prevention, but saving money, okay? So February 2008, right? Several months before the presidential election, New England Journal of Medicine. The title of the article, Does Preventive Care Save Money? Health Economics and the Presidential Candidates. Now, this was at a time when each of the three, so Edwards was still in, so this is Edwards, Obama, Clinton, on their websites, each said, we're going to pay for the uninsured with preventive care. All three of them. Okay, all three of them. So, New England Journal, Milton Weinstein, pretty big deal economist, quotes, candidates have offered plans for controlling spiraling costs. These statements convey the message that substantial resources can be saved through prevention. Although some preventive measures do save money, 82% from our review in the health economics literature do not. How can that be? Okay, so let's talk smoking for a minute. And I'll do it without, I'll sort of give it to you in 2 or 3 ways, because it's important to think about this. The first thing that you want to ask in does prevention save money is for whom and when. Okay? Now, I wouldn't let you do that, right? No, you can't do that, okay? But it's for whom and when, right? It turns out that breaks taken by smokers at work waste more money for the employers than do the medical costs, okay, when you add it up. So for the, it's here tomorrow, you can, as opposed to my usual, just trust me, it's here. It turns out they take a lot of breaks, the smokers. And then they had some really interesting things of presenteeism and absenteeism. The presenteeism was really interesting, which means you're not doing as best as you can and still you go to work. And there's some data on that with smokers. Okay, that's not the big deal. The big deal is as follows. The study by Baumgartner, New England Journal, a couple of years ago, referenced here. And this was from the Congressional Budget Office. You know how accurate they are sometimes. But they wrote a really, to me, very interesting paper where they looked at the eventual 30-year effects on the federal budget of an increase in the cigarette tax by 50 cents a pack. Now, for those of us that didn't know what it is now, it's about $1.01, and so it's basically a 50% increase in the federal cigarette tax. What happens? Okay, what happens, we'll work it backwards, is that people don't die. People don't die and they stay alive just long enough to get the next disease. So we've got to come back to that one, okay? Because that's important. But in this study, they modeled out, and in fact, it was cheaper, right? It was cheaper for the federal government to have people smoking than not smoking. Now, what does this have to do with reality? What this has to do with reality is, again, whose perspective are we talking about? If we're talking about an employer, right, we're talking about an employer, all the employer wants to do is get you to 65.1 years, because then your health care costs go away from them. Okay, so that's what the employer's goal is. And so the employer, if you look narrowly at some of the data in, what are the expenses to employers, if they can prevent the younger types of cancer and just get you to 65, they don't get it with the older types of cancer or other things. So the issue with any of these, and there is not a good study, I almost tried to do one once, so I know they're not out there, is to model what happens to you when you prevent disease A and you get disease B, because guess what, we're all going to die. And so from the big macro, if you're the federal government and you're looking at Medicare spending, which is what this was doing, in fact, it's cheaper to smoke. Now, again, I told you I'd say this 15 times. That's not the point. I'll give you, any of you economists in the room, you can actually calculate, because healthcare costs are going up about twice the rate as medical care, or medical and healthcare inflation is about twice the rate of regular inflation, right? And so it actually costs about, purely adjusted, costs about 13% more to die 10 years from now than it does now of the same disease, because it's more expensive in an inflation-adjusted way. So this is not, I'm not trying to be facetious because it's important. Point one, and then I want to throw it open to the panel, and we've got 3 minutes, so I want the panel to say what they'd like in 3 minutes. But the point is, this is complicated. It's not, if you're looking for money and you're looking to fund the uninsured with prevention, as one of you said, that money isn't there. I wish it was, but it's not. Now, panel.
Can I comment on something that's even nastier than cigarettes? One drug has probably increased our costs more than any other drug that I can think of, and that's insulin. Insulin, when we had juvenile diabetics, they didn't get old enough to work because they died. They didn't reproduce because they didn't get pregnant. Diabetics who get insulin get pregnant and they work, but they still have the morbidities associated with diabetes. They don't go away. And because infants of diabetic mothers have an increased risk of diabetes themselves, you increase the costs exponentially as you go forward generation after generation. Now, I, like Tim, am not saying we shouldn't use insulin, but be careful what we ask for when you're asking for prevention.
I think
Others.
another point I add on to that is that prevention is not something we don't want to do.
Correct.
It's a
Correct.
moral imperative.
Correct.
But it's not the argument. It's not part of the financial argument about how we're going to save the healthcare system. It goes back to the two fundamental questions that we've got to answer before we're going to have an effective healthcare system. Is healthcare a universal right? We've never really addressed that universally. And if it is, who's responsible for it?
Who's going to pay for it?
We're in a country that, who's over a long history has claimed we want to limit the federal government and strengthen the states. We're seeing it doesn't work. And this is a big cultural change, and that goes back to your idea that we're in a slow evolutionary path, and we're going to need that kind of leadership and the people in this room to take us to the realization that we need to change our value system so we can put into gear some of these things that need to be done.
I'll buy that. Two more real quick.
Oh, so another example, we're talking about prevention having costs, right? Newborn screening programs just had a baby, so this is in my mind, right? But you say like, oh, you know, an $80, $50 test could have saved baby X, but you don't factor in all the babies Y and Z that don't actually have the condition, right? Again, it's an example of something that's really great that we do it. But then also when you factor in false positives, also there's false negatives, so then parents go on these odysseys trying to figure out what's actually wrong. It's something the reason to do it is because it's the right thing to do, not to save money.
And I'm going to say we have to optimize preventative health care. I don't think we know what it is. Right. I think we're still finding our way. And when I look at curriculum in our academy in pharmacy, we have not been addressing key areas like nutrition, motivational interviewing, psychology of the patient, the health belief model. These are things we are still in an infantile stage. But we're going to continue working hard. But again, back to evolution, it's going to take us a while. And what do we remove when we add these great areas in our curriculum?
Lamar, there's no such thing as evolution. Gene.
And so I think, recently people in the last couple of years are talking about value-based healthcare, but then it brings into to mind all these existential questions, right? What is value, and then what is value to whom? So is it value to the individual patient? Is it to their family members? Is it to the provider? Is it satisfaction? And so I think we're still struggling trying to figure out what value actually is. And we throw around all these little equations, but we can't get the equation to spit out the right number yet.
You guys have been amazing. Thank you, panel. And now, this stuff, we've got drinks and food for the next 45 minutes-ish behind you. Stick around. You've been tremendous. Thank you, audience, and thanks for coming.